Welcome to the Black Belt Nurse Podcast, where we discuss all things related to violence in healthcare. I'm Bill Schuler, your host, and this is the place where we learn together, mull things over, and generally figure things out. Whether you're a seasoned expert, a student, or just passionate about safety in healthcare, this is the podcast for you. Before we dive in, a quick disclaimer. We do discuss all aspects of violence in healthcare, some of which may be inappropriate for younger listeners and viewers. Please use discretion. The Black Belt Nurse Podcast is for informational and educational purposes only. While we discuss experiences, strategies, and science, this podcast does not provide medical, legal, or professional advice. Always consult your healthcare institution's policies and guidelines or seek professional advice when necessary. And of course, all opinions expressed here are my own and do not represent any employer or organization. Now, let's get started. Is violence part of the job? Now, we've been reviewing a study called Nurses' Perceptions and Expectations of Patient Violence, Language Matters. And in part one, we looked at the results of 3 questions. And in part 2, we delved into each question and more of what the nurses responded to those specific questions. So very brief recap. The first question is, do you think it's possible to prevent patient violence and achieve 0 incidents of violence? And 15% said yes, 85% said no. Question number 2 was, do nurses in hospitals expect to be exposed to violence while at work? 81% said yes, 19% said no. And in question 3, the question was, should nurses in hospitals expect to be exposed to patient violence while at work? And 32% said yes, while 68% said no. So in this episode, I want to dig a little bit more into the discussion of the study, as well as a couple more things that they brought forward in the discussion. So in thinking of the study as a whole, in their discussion, the authors put those who felt patient violence in hospitals could be eliminated were less likely to expect it. And those who felt it could not be eliminated were more likely to expect it. So you have a differencing of opinions where, hey, we could get rid of it. I'm pretty gung-ho. We shouldn't expect it. I shouldn't expect it to happen. And then those who felt that it couldn't be eliminated were more likely to expect it. So more, in my opinion, more of a realistic expectation or a view on the reality of violence in healthcare today. The authors also go on to say these results highlight conflicting interpretations regarding patient violence. Some respondents felt strongly that violent patient behavior was willful, while others interpreted it as a confluence of factors. It is possible that interpretations of events are related to tolerance and/or expectation. For example, patient behaviors in labor and delivery settings are interpreted as expected, while some behaviors are interpreted by medical surgical nurses as unacceptable. So there seems to be a slight tolerance of the patient type or even of the area in the hospital, what the patient is going through. They say staff members with more tolerant behaviors have reported less burnout and greater sense of personal accomplishment. That is reflected in other studies as well, where if you come to expect it and you're like, it is part of the job, I'm going to be aware of it, I'm going to do my best to prepare for it or mitigate it or even prevent it, there seems to be less burnout in those, and they've incorporated it into their practice. They also say behavioral intent is typically beyond the scope of practice for nurses, but it is obvious in some of these responses that it is something that nurses often do informally. So looking at, did this patient intend to commit violence or intend on hurting somebody? They say ascribing intentionality to patients' violent behavior has been linked to a heightened emotional reaction and increased likelihood of reporting events. I think what they mean in this is that if a nurse feels that the person intended to commit violence, that it feels more egregious, and they're more likely to report it because they felt it was intentional, even though it's not within our scope as nurses to say, did they intend to do it or not? In my experience as a clinician, as a nurse, when we feel or we understand, or I would say we even know that somebody did not intend to do what they did, we're less likely to report it. We're more likely to accept that as, hey, their disease process is what is causing, or the situation is what is contributing to it. They also say expecting patient violence was not conflated with accepting patient violence. They acknowledge that patient violence was expected, but not an approval of patient violence. So we can acknowledge that patient violence is going to happen. It can happen. The risk for it is fairly good if you work in healthcare, but I don't have to say, okay, I accept that. It's okay. So we can acknowledge that, all right, this is the reality. It probably will happen. The risk for it is there, but I don't have to say it's okay. They also go on how the participants compared nursing to other professions like teaching, banking, and law. And I think the authors do a very good job of kind of parsing this out. They talk about teachers, bankers, lawyers, and nurses all enter fiduciary relationships, meaning that they are duty bound to act in the best interests of the other party. There are critical differences, though, between nurse patient relationships and a teacher student or a banker customer or a lawyer client relationship. They talk about hospitalized patients are ill or injured to the point of needing medical and nursing care where you can't get this anywhere else. And it's an expectation that doctors and nurses utilize their specialized knowledge and skills in service of these vulnerable people. So you think about it, a teacher student relationship can be severed, a bank customer relationship can be severed, a lawyer client relationship can be severed. But once that patient is in a hospital and in the setting and they're in front of you, you're expected to care for that person. Now, let's say they are violent and you exchange one nurse is, I can't take care of this patient. You're going to substitute another person. So the risk is still there, even for the next person. So it's a little bit different of other professions. We can talk about it in the emergency setting where if a person is violent and the law requires a medical screening exam, you have to do something, you have to take care of them to rule out an emergency medical condition. So context matters is what they're saying. It's not apples to apples, it is different. They also highlight that the nurse's role as a helper is a rationale for not expecting to be exposed to patient violence. I'm a nurse, I'm here to help people. Therefore, I should not be exposed to violence or I should not expect it. And they talk about, well, American nurses are responsible for adhering to the code of ethics for nurses. There is not a concomitant obligation on the part of patients. So the patient nurse relationship is not quid pro quo, right? The expectations are not the same both ways. I think that's pretty good to highlight too. Now, earlier in the study, before they go into the discussion, they talk about an incidental finding that they found was pretty surprising. And they talk about the number of derogatory or pejorative comments made about patients. They talk about how in their narrative, some of the respondents called patients entitled, they called them awful, they called them jerks, they called them horrible. Some people might have mentioned that mental health diagnoses were viewed as excuses rather than legit medical issues. They talk about how beyond accountability, some nurses wanted retribution or wanted the person to pay for what they have done. So they explored that a little bit more in the discussion. They say it's understandable that nurses exposed to patient violence want the behavior managed and they want the opportunity to seek justice if they believe a crime has been committed. But they say these comments might simply indicate the level of frustration nurses experience due to patient violence. At the same time, vengeance is incongruent with the stated values of the profession and likely has a place only in limited, if any, situations. Now, okay, let's take the word nurse out of it. Nurses are people. And if you're a person that experiences higher than average violence or you're exposed to violence much higher than the average person in their job or even outside of the job, wouldn't you expect them to be frustrated? Wouldn't you expect them to go to this? They're awful, they're jerks, they're entitled. To me, this is normal. This is a normal part of being a human being. And nurses are human beings. It's not surprising to me. It's not surprising when nurses, it's been labeled that if you work in the ER, it's one of the most dangerous places to work. For nurses and for people to respond or make comments like that, to me, that is normal behavior. That's venting. It's not surprised. I know they say vengeance is incongruent with the stated values of the profession. Hey, this is normal. This is normal human behavior, in my opinion. In their introduction, they talk about zero tolerance a little bit. And I just wanted to highlight that and just address what they say. So what they say about zero tolerance in their introduction is that it's a potential contradiction in workplace violence campaigns that promote zero tolerance approaches. They say these approaches suggest that people who exhibit violent behavior, including patients, will be withdrawn, removed, or punished in some way. Which, if you look at the true definition of zero tolerance, it's a punishment for an infraction of a rule, regardless of the circumstance or the context. If you use the word zero tolerance in your policy, this is what it means. And that typically should be the expectation that there's some consequence. Either they're removed, they're withdrawn from the situation, or they're punished in some way. The authors go on to say zero tolerance as a policy approach has roots in the criminal justice system and implies that people are responsible for their behavior and must be held accountable. Now, what they're referring to is the broken windows theory. Now, it is debatable whether zero tolerance has its roots in the criminal justice system. The broken windows theory is if in a society or in a place where you start getting areas that are run down, you get one broken window. Soon, if you don't intervene on that type of behavior, apply a consequence, that there will be more broken windows, and that, that society will kind of start breaking down. It makes its way into violence prevention, and it's debatable whether zero tolerance is based off of that. But they say zero tolerance language used in workplace violence campaigns gives the impression that it is permissible and possible simply to remove patients who exhibit violent behavior from hospitals despite established fiduciary relationships, ethical frameworks for safe discharge, and federal laws protecting vulnerable patients. That is true. It's too simple, right? Zero tolerance, the word is way too simple. The concept and the application is much harder. There's going to be an entire podcast episode on zero tolerance where we dig into this. And the authors lastly go on to say whether this is the intended purpose of such approaches, this is how they have been interpreted by staff members, leading to a disjunction between policy intent and practical application. Yes, I agree with that, and that will be in a future episode. So now I'm going to give my perspective and my opinion. Is violence part of the job? If you work in healthcare, yes. Unfortunately, it's a reality nowadays. We have plenty of data, like I've shown you in part 1 and part 2, that violence is here. It's already a problem. It's nothing new. It's been here for a while. You've got the OSHA data. You've got the Bureau of Labor Statistics data. For nurses, violence is consistently 4 to 5 times and sometimes 6 times the rate of any other profession or job, especially in the private sector. It's been that way for a long time. And if you're a tech, a CNA, an aide, it's even worse for those professions. And if more than 75% of injuries from workplace violence happen in healthcare, that's another statistics that shows it's a significant risk of the job. And we know that studies and surveys consistently show that healthcare workers experience violence at a pretty high rate. If I reflect back to the National Nurses United study, they showed that almost 70% were verbally threatened or verbally harassed. You had more than a third were physically threatened, and more than a third were actually physically assaulted. We know that the patients that come to us, their disease process can preclude them to being agitated and having violent behavior, whether that's medical, whether that's psychiatric, or we know even the systemic factors contribute to it. So you've got lack of efficiency, you've got long waits, you've got boarding, you've got overcrowding, you've got lack of safety and prevention, you've got lack of training, you've got federal laws that just say, hey, they're here, you have to take care of them, regardless if they're violent or not. You got many factors that influence violence happening in healthcare. And those people come to us. Those people, we invite them in. We want them to come in. They're brought in, sometimes against their will. Sometimes they don't even know what's happening. And sometimes law enforcement brings them in too. We also have, on the flip side, the systemic issues. You've got lack of efficiencies. You've got long waits. You've got overcrowding. You've got lack of safety and prevention initiatives and training. And you have federal laws that say if somebody comes to you seeking care, especially in an emergency department, that you have to assess them for an emergent medical condition, which you cannot just throw them out of the building because they're violent. So we've got all these factors contributing to and funneling into violence happening in our hospitals. So is violence part of our job? Unfortunately, yes. The risk is high. The risk is significant. Should it be so? Absolutely not. We can expect violence, but we don't have to accept it. Why do we think that because we are in a helping profession, that people should not be violent, or that us being helpers will save us from violence? When people come to us, they're needing something. They're coming to us for help. And so when it happens, like, we're committed to caring for people. And then when something happens, it can feel like betrayal. And the authors highlight that in their study too. And to explore that, why does it feel like betrayal? Number one, you've got the physical injury. That can be bad in and of itself. Then you have the emotional or the psychological injury that happens afterwards, sometimes for a long time. You've got feeling betrayed by the patient or the family on their behavior and how things happened. You can feel betrayed by the hospital, by you saw this, you didn't do anything to prevent it, and they hurt me. Or I'm hurt and you're not helping me, you're not supporting me. And then you've got maybe betrayal by the judicial system. You've called law enforcement, they don't want to take your report, they dismiss what happened, or the district attorney or the prosecutor doesn't do anything about it. In my opinion, staff safety should have just as many resources as patient safety. You think of all the stuff we've done to make our workplace safer regarding bloodborne pathogens, or around infectious disease, or around maybe safe patient handling, where there's campaigns, there's education, there's equipment, all to help not only us be safer, but also to have our patient care be safer. Should our goal actually be zero? Should our goal be zero violence? I don't think so. We'll never get to zero. It's a laudable goal, but we can't have zero tolerance. With the laws that are in place, with them coming to us and they're already violent and we're trying to care for them, we can't expect zero. We can't even enforce zero tolerance. There will be a whole episode on zero tolerance in of itself. And then let's say it does happen and we try to have staff become more resilient. What does that mean? Does that mean that healthcare workers are not resilient already? Does it mean that they can't handle it? What if we reframed it from violence is not part of the job to it is part of the job, or the risk is significant? there is a significant risk of being assaulted while I'm at work. If we reframe that, what would it change for you? Would it change how you went about your day, how you planned your care? Would it change what committee you participated in? Would it change what you ask for safety-wise? Would it change how you assess patients? Would it change the tools you use? Would it change how you communicate a risk for violence to your fellow staff members? What would it change for you if you acknowledged and internalized that violence is part of the job? Violence is a significant and known risk to the job. What would that change for you as a caregiver working in healthcare in America today? That's it for this question. Is violence part of the job? I hope you'd enjoyed this 3-part series, and I hope you learned something, and I hope it influences something about your own personal practice as you continue to work in healthcare today. That's a wrap for this episode of the Black Belt Nurse Podcast. If you enjoyed this episode, don't forget to like, subscribe, and hit that notification bell so you never miss a new episode. Drop a comment below and let me know your biggest takeaway. I would love to hear from you. You can find me on LinkedIn and Facebook, as well as blackbeltnurse.com. For now, be safe, and I'll see you in the next episode.